Lakshmi. She's very fond of comments. So this is an unusual mechanism and unusual combination of two common diseases. The mystery of the misdiagnosis can never be solved. Now, she was a 36-year-old female. She had a classical history of rheumatic fever. In 2005, she had a progressive shortness of breath. In 2006, a balloon mitral valvotomy was done in a leading cardiac center. I have highlighted it for some reason. Symptomatically, she was better. Then in 2010, again, she had a recurrence of symptoms. In 2011, a repeat BIP was at a leading cardiac center again. Symptomatic again became symptomatic in 2019, and the 3D TE was performed somewhere else, and the report was with a 3D MBO of about 0.8, pulmonary artery systolic pressure of 50, soft LLA clot, and no other significant abnormality seen. So then she came to us, the BP was normal. There was a diastolic and possibly soft systolic murmur. She was on digoxin, furosemide, and other things, and the other tests were repeated. The ECG showed a right ventricular predominance. There was no LVH, and when we did the echo, the first thing we struck was a severe IVS hypertrophy. Now, in absence of hypertension and aortic stenosis, why there be a severe IVS hypertrophy? And there was a doming of the anterior mitral leaflet, and it was coming and almost obliterating the LVOT. And on a color flow mapping on the right side, you see that there was a turbulence in the LVOT also, and this was a massive thickening of the septum and the doming. This was a still image to show that there was no systolic anterior motion of the mitral wall. This is in systole. Again, this is a zoomed view to show the same thing, a marked septal hypertrophy and the mitral wall abnormality thickened with a doming, and the LA is enlarged. Then on MOD echo, you see a very interesting sign of a mid-systolic closure of aortic wall. This mid-systolic closure of the aortic wall is one of the signs of a hypertrophic obstructive cardiomyopathy. You can see this in MOD echo. Then the mitral wall orifice area was about 0.8 centimeters square. Then on the three-chamber view, you can see there is a significant hypertrophy of the septum and the mitral wall trying to obliterate the LVOT or so. And you see a turbulence across the LVOT. And the same thing was seen in the transesophageal echo, besides a spontaneous contrast echo, you see all the same findings of the mitral wall which we have recorded. And you see a severe turbulence across the mitral wall because of stenosis. But when the Doppler was done, it showed a LVOT gradient in systole. So the question was, all the other signs are present in diastole, but a gradient across the LVOT was present in systole. So the problem was, there was a diastolic obliteration of LVOT. However, LVOT gradient was in systole. So there had for that. And how HOCM was missed by three big centers will remain a mystery of the century, because we cannot say, because it is so evident also. So then this condition is so uncommon that in Mayo Clinic in 22 years, they could see about 12 patients or so, and they were mostly a degenerative type. And they have four mechanisms. One was a systolic anterior motion with severe limitation, which was not present in this case. A severe limitation of mitral wall lifter mobility with systolic anterior motion as a tip, which was not present in this case. A septal encroachment toward the LVOT, which was present but not to explain everything. And MV displacement because of calcification, which was not present in that case. We had only one case from India, unusual coexistent rheumatic stenosis with hypertrophic. The images were not moving there also, and they had showed a sand of the anterior mitral leaflet and a gradient also again in systole. So now the questions come, what was the cause of this systolic anterior motion, for this a systolic uh, uh, velocity when everything was in diastole? Any suggestions from our friends? So everything is in diastole, but why the gradient was in systole? So if you see here, the mechanism was unusual mechanism. It was the hypertrophic papillary muscle which was hitting the septum. So it was nothing to do with the mitral stenosis. It was the hypertrophic papillary muscle which was producing. You see, there's a marked obstruction of the LVOT, and you can see at the same time that it was present here. So you have to explain some symptoms, whether they were present or not. And so when to suspect is awareness, signs of mitral stenosis, LV type of apex beat, which was not present in this case, ECG signs of LVH, which were not present in this case. So the treatment initiated was stop digoxin, furosemide reduced, and a negative inotropic agents started. So the management is, now if this lady would have been diagnosed much earlier, unfortunately what happened that as we told her what is the cost of the mitral valve replacement and the septal ablation, because she was from a different state and there was a severe pandemic at that time. So she could not go to the state, and one day she developed an acute pulmonary edema and died. So I think if this diagnosis would have been kept much earlier, so something would have been done. So that was that LV replacement alone may not correct outflow tract obstruction when the cause is not related to systolic anterior motion and concomitant alcohol synthesis to be done. So lessons learned, see the patient as a whole, never, and do not focus only on a primary disability. Always explain why. If some abnormal finding there, why you have to explain it and correlate finding with some unusual mechanism. So that is it was a Y syndrome in this case. And while I was taking this, suddenly this came to me. Anything, anybody have, what is this Doppler finding? सब नीचे देख रहे, ऊपर देखो. Because this is a finding which is seen in cases of a apical hypertrophic cardiomyopathy with a mid-LV obstruction. Very rarely you get it, and this is what is known as a lobster claw hand deformity. This is lobster claw hand deformity. This systolic wave is because of this connecting. No, घंटी दूसरी भी बच गई. So this is the thing. And lastly, the most important slide of the day is a thank you, and India and Bangladesh going on shaking hands.